So, assalamu alaikum. Good evening, good morning, or good afternoon, everyone. It's a great pleasure to be with you this evening, and I'm very thrilled to celebrate with you this special milestone as this webinar marked the 50th webinar of MENASO. This educational event have been a great success, and I would like to thank all members and all the guests and audience who participates in those webinars. With your commitment and engagement, we can advance stroke care, and we are committed at MENASO to be the voice of stroke in the region. And we are very delighted to celebrate this evening with a special group of experts, regional and international. So all the way from Kuwait, Iran to Boston. Without further delay, I would like to give the mics to Dr. Mohammed and Dr. Nazar, our moderator.
Thank you very much, dear Dr. Adel. Hello, everyone, and welcome to the 15th MENASO Education Academy Cerebrovascular Ground Round. And the first MENASO VIN joint webinar and navigating stroke risk. Update on carotid and intracranial occlusive disease. Our webinar series successfully gathered the global community of over 9,000 participants last year. And this success is due to our esteemed lineup of 48 speakers, including both local and internationally renowned professors and consultants. We are delighted to have you all here today. Dr. Nazar.
So today we will explore the complexities of cerebrovascular medicine with Dr. Mohamad Abdalkader, discussing intracranial occlusive disease, case-based spectrum of pathology and treatment. Dr. Athari Salmeen covering the updates on carotid artery disease management, symptomatic and asymptomatic. Dr. Shareefa Alrushaid will present a case study titled An Approach to Stroke in Young with an Abnormal Vascular Imaging. And Dr. Ohood Almutairi will present a case study on stroke with a twist, the unexpected rare finding on CTA. These are highly relevant topics, and I'm sure you will find them both insightful and informative.
Before we begin with the main talks, we will first go through the case presentation, starting with Dr. Shareefa Alrushaid. Dr. Shareefa Alrushaid is a medical doctor who obtained her degree from Kuwait University in 2022. She has an interest in neurology and almost 2 years of experience working within neurology unit at the Jabir Al-Ahmed Sabah Hospital in Kuwait. She's going to start her adult neurology residency program at the University of Toronto this summer. Shareefa also has an interest in research and is currently working on a study surrounding the topic of stroke in women in Kuwait. So, Dr. Shareefa.
Yes, thank you for the introduction. So today I'll be presenting a case about an approach to stroke in young with abnormal vascular imaging. I'll just try to share my screen. Okay. Can everyone see my screen?
Yes, we can see it.
Okay. So this is an interesting case that we saw at Jabir Hospital recently. I have no disclosures. So this patient was a 29-year-old female with no known past medical history, and she presented to the hospital with sudden onset vertigo. This was not associated with any headache, focal weakness, or sensory deficit. She did, however, experience difficulty in speaking, which was transient, and she denies any headache or diplopia. She was able to recall the event. There was no loss of consciousness or abnormal movement, no behavioral change. And in the past 4 days, she had visited the ER 3 times for fatigue and was discharged home. Her husband states that she was unable to speak properly throughout those last 4 days. Her drug history is insignificant. Her social history, she is an employee at a governmental body. She's married, she has 2 children, no previous history of miscarriage, and she's a non-smoker. Her parents are consanguineous, but she doesn't have any family history of stroke in young, epilepsy, or autoimmune disease. And on systemic review, it was mostly unremarkable. Neurological exam was also normal, appeared from a language assessment, which revealed impaired fluency. So when we were assessing her language, she was able to understand, repeat, read, write, and name, but her sentences were not complete. She was stopping and freezing in between sentences, and she had impaired fluency. So we ordered a plain CT, and this is what the initial CT showed. So you can see that there are multiple hypodensities. You have one in the left anterior temporal lobe. There's one also in the left occipital lobe. You have also a hypodensity in the right MCA area, and they're all of different densities. So they seem to be of different ages. So we followed up with a CTA, and this is some images from her CTA here. So you can see in the first 2 blue arrows, images A and B. If you look at the left internal carotid artery highlighted by the arrow there, you'll notice that it is narrower than the right internal carotid artery. And then also if you look at both MCA arteries, they seem to be very thin. And her left MCA in figure G, you can see there's some focal stenosis. So although their patency is intact, but there seem to be some areas of stenosis. This is also her CTA in a coronal view and reconstructed imaging. Again, here you can see the left internal carotid artery is narrow compared to the right. MCA and ACAs are both patent in reconstructed imaging. So we ordered basic blood work for the patient, and she was started on single antiplatelet therapy because we didn't know what we were dealing with, which of her strokes are acute. We ordered a full stroke in young laboratory workup. Her initial workup showed an elevated CRP of 139. So there was a slight concern for infective endocarditis. So we started her on antibiotics until we were able to exclude that. We did an urgent echocardiography bedside, which was normal. And we sent 3 cultures according to infective endocarditis protocol, which were also negative. TEE with bubble was also negative, and serial ECG showed normal sinus rhythm. This is her MRI, so you can see that she has, out of all of the hypodensities that we saw, she had 2 acute infarctions. So the one in the left anterior temporal lobe is showing diffusion restriction, and you have one in the left basal ganglia as well. And mind you, the patient is completely asymptomatic. She denies any previous history of stroke or stroke-like symptoms. She refused a lumbar puncture, which we wanted to do just to get a bit more information about what was going on. So when we completed the workup, we discharged her home and gave her a referral to neurosurgery to perform a DSA and an OPD appointment to follow up with us as well. So this is a DSA of the right carotid artery. You can see here in the blue arrow is her anterior cerebral, the beginning part, and the red arrow is showing the beginning part of the middle cerebral artery. So you can kind of see the beginning of both of those major branches, but then you can't really see the rest of the MCA and the ACA. There are some peripheral small branches there, but the large arteries you can't really see very clearly. And it's even worse on the left side. So here you almost cannot see the MCA or the ACA at all on the left side. So just to review her diagnostic workup, ANA was positive, but all her autoimmune panels came back negative. We also ordered autoimmune encephalitis and paraneoplastic encephalitis panels in the serum because we weren't able to do lumbar puncture, and those came back negative. Her thrombophilia workup was negative. Virology and syphilis were also negative. Homocysteine was normal, and HB electrophoresis was normal. So just to go over the differentials that we were considering in this case, one of the things we were considering was RCVS, but we excluded that mainly because the patient didn't have any headache. Her imaging was consistently abnormal, so it wasn't something transient that occurred and then patency was established. And she had findings of old infarcts on imaging, which doesn't really happen with RCVS. Moya Moya was also excluded because it's an angiographic diagnosis, and DSE did not show that typical Moya Moya phenomenon that you would see. And she had mainly, she didn't have exclusively anterior circulation involvement, although you can rarely see posterior circulation involvement in Moya Moya, but it's not typical. Secondary autoimmune CNS vasculitis was also ruled out based on the fact that she didn't have any symptoms of systemic disease and workup came back negative. So we were left mainly with two different differentials, which were primary CNS vasculitis and genetic vasculopathy. So primary CNS vasculitis actually typically presents with headache, progressive cognitive impairment, encephalopathy, seizures, and there are two main phenotypes. So you can either have a small vessel involvement or medium to large vessel involvement. And it's suspected clinically, but it is a histopathological diagnosis. So we weren't able to do biopsy for this patient, but clinically there was suspicion that this could be a primary CNS vasculitis. And this is an example of imaging that you would see in such a case. Genetic vasculopathy, she doesn't fit into the more common ones that we think of, like CADASIL and CAROTID, because those mainly cause small vessel disease, but there are over 50 genes that can cause genetic vasculopathy. So there could be something that can explain her presentation. We're still waiting on genetic workup for this patient. But we started her on steroids, prednisolone, and we had planned to start her on rituximab in the future, but we're still waiting on genetic screening just to see where to go from there. So a question we might ask is, what determines the choice of antiplatelet therapy? It depends on the differential that we're considering. So in primary CNS vasculitis, the main treatment is treating the cause. So there's an inflammation in the vessel wall that you want to treat with something anti-inflammatory, steroids mainly. And then you want to maintain immunosuppression with something like rituximab or cyclophosphamide. But aspirin is considered an adjunctive therapy that can be used for secondary prevention. The same goes to genetic vasculopathy. It's proven to be useful and recommended for stroke prevention in such cases. So in conclusion, DSA provides useful information when dealing with a young patient with abnormal vascular imaging and should be considered in all young patients with abnormal vascular imaging. Primary CNS vasculitis is a histopathological diagnosis. Angiography alone is not diagnostic. Most genetic vasculopathy phenotypes involve white matter disease, but there are some rare instances where medium to large vessel involvement can occur. So we're still in the process of working this patient up, but those are the main two differentials that we are considering. And thank you.
Thank you, Dr. Shareefa. And let's go through the second case by Dr. Ohood Almutairi. Dr. Ohood Almutairi is a neurology registrar and postgraduate year 3 resident in the Kuwaiti Board of Neurology, currently working at Jabir Al-Ahmad Hospital. She is dedicated to the diagnosis and management of neurological disorder with a strong commitment to patient care and medical education. Dr. Ohood Almutairi continues to enhance her experience in neurology through clinical practice and ongoing professional development. Dr. Ohood.
Thank you, Dr. Nazar. So I'll just try to share my screen. Okay, you can see my screen?
Yes.
Yes,
Okay.
yes.
So, my name is Dr. Ohood Almutairi. I'm a third-year neurology resident. Today, I'll start with an interesting case that we saw in our hospital. Okay. So this was a 50-year-old female. She was right-handed, previously healthy. She presented to our hospital with history of right lower limb heaviness and difficulty speaking upon waking up from sleep. This was noticed by the patient herself and the family as well. Her past medical history was unremarkable except for mild headaches that were on and off. And then the drug history was also unremarkable. The patient was not on any medication. Her social history, she's a non-smoker. Other history was unremarkable. On examination, her blood pressure on arrival was 192/109. It was high. Heart rate was 100. On examination, the patient was alert, she was oriented and cooperative. She had mild dysarthria in the form of slightly slurred speech, but it was intelligible speech. Her comprehension, repetition, and naming were all intact. The patient also had mild leftosis. However, she reported this is since birth, and this was confirmed by old photos. All other cranial nerves were unremarkable. On motor examination, bulk and tone was normal throughout. Her strength, upper limbs were 5 out of 5 bilaterally. However, on the right lower limb, it was mild weakness, graded as 4+. Sensory, reflexes, coordination were all intact. Her gait, she had a slight heavier step on the right lower limb due to the mild weakness, but she was able to ambulate independently. So her initial routine in the ER was unremarkable. So we went for imaging. CT brain, CTV were unremarkable. However, we did find something on the CTA. So let's look at this coronal view of her CTA. Let me see if I can do a laser. Okay, so you can see here the right common carotid artery going up and splitting into the right ACA and the right ICA. However, on the left side, you can see one artery that is of a smaller caliber comparing to the right, and it's continuing up as a single artery. Okay, so this was the picture I showed you. This is the common carotid artery going up as the right ECA and the right ICA. However, on the left side, you can see only one single artery as the left ECA, and you cannot see the left ICA. Okay, this is when you go up, you can see the left ECA, but we have non-visualization of the left ICA. So let's look at a different view. On axial image, it's the same finding. On the right side, you can see the common carotid artery splitting into the ECA and ICA. However, on the left, you can see only a single artery, that is the left ECA, continuing as the left ECA, and we have absent left ICA or non-visualization of the left ICA. So is this an absent ICA, is this an occlusion, or is this congenital? How can we tell? We have to look at the bone view or the skull to differentiate. So this patient on the right side, you can see a clear carotid, internal carotid artery foramen. However, on the left side, you can't see it. So the patient had marked hypoplasia of the left carotid canal in the skull base, which goes with a diagnosis of a congenitally absent ICA. So let's look at the posterior circulation in this patient. You can see here the two vertebral arteries that go up to join the basilar artery, and the basilar artery in this patient was stenosed throughout. It was a small caliber throughout, so she has a clear basilar artery stenosis. So if this patient has an absent internal carotid artery, where is the MCA coming from? So you can see here clearly the left MCA, which is coming from actually the posterior circulation from a hypertrophied posterior communicating artery that is supplied by the left PCA. So on the report, the patient had a non-ossified left ICA, mostly due to congenital absence of the left ICA. This was supported by marked hypoplasia of the left carotid canal in the skull base, as well as a uniform small caliber of the left common carotid artery, and it continues as the left ECA. So the left ACA, which was not clear on the CTA, but I'll show you on the MRA, the left ACA is supplied by the right ACA via ACOM, and the left MCA is supplied by the left PCA via hypertrophied left PCOM. And the patient also had a clear basilar stenosis. So the patient was started on dual antiplatelet therapy, high-intensity statin, and blood pressure was kept on autoregulation. And we ordered MRI brain. So this is her MRI brain. It showed a left paramedian pontine acute infarctions. However, when you look at her MRA, you can see clearly the left ACA is being supplied by actually the right ACA, and the left MCA is being supplied by the left PCA. Here you can see clearly the right ACA, but here you have non-visualization of the left ICA. So what are the challenge questions in this patient? How to differentiate between a congenitally absent ICA or a complete occlusion or dissection of the ICA, which I will explain later. And then we have how to manage the basilar artery stenosis, knowing it supplies both the anterior circulation and the posterior circulation in this patient. So absence or congenital anomalies of the ICA. This was first documented case of the carotid agenesis discovered on postpartum examination in 1787. and it was first described in angiographic image in 1968 by Dr. Lai here in this book, and he classified agenesis of the ICA into 6 different types based on collateral circulation, which I'll explain later. So agenesis or hypoplasia of the ICA is rare congenital anomaly occurring in less than 0.01% of the population. And out of this percentage, less than 10% will be bilateral absence of the ICA. So interestingly, the ratio of the left to right ICA is approximately 3:1. This is similar to our patient. And the patients with congenital absence of the ICA have no clinical symptoms due to compensation by the collateral circulation of the circle of Willis. So what's the hypothesis behind this? It's thought due to embryonic developmental failure from the third aortic arch. The ICA develops from the third aortic arch before the embryologic stage at 24 days. However, the skull base starts to develop around the 5th week of gestation. So if the ICA is absent congenitally, then the carotid canal will fail to develop. So this is how to differentiate between the two. So we have to look at the CT scan. Okay, so as I mentioned before, Dr. Lai has divided agenesis of the ICA into 6 different types. Type A, you can see here the left ACA is supplied by the contralateral ACA and the MCA is supplied by the posterior circulation. In type B, both the ACA and the MCA is supplied by the contralateral ACA. And then in type C, where the patient has absent bilateral ICAs, both the ACAs and the MCAs will be supplied by the posterior circulation. And then in type D, it's very important for neurosurgeons to recognize this type because the patient will have a siphon section. So the ACA and the MCA will actually be supplied by the contralateral ACA through an intergubernalis branch. So if they do a transsphenoidal arch surgery, they have to recognize this type. Okay, then we have type E and type F, which are rare. Okay, so which type does our patient have? Like we said before, the patient has a left ACA supplied by the right ACA, and the left MCA is being supplied by the basilar artery. So actually our patient has type A, which is the most common type. Okay. So does agenesis of ICA has any associated conditions? Yes, they have a higher risk to develop cerebral aneurysms. The estimated prevalence of cerebral aneurysms in the general population is about 2 to 4%, but the reported prevalence of aneurysm in association with the absence of the ICA is about 24 to 34%. Why do they have an increased risk to develop cerebral aneurysms? Because of the increased flow through the collateral vessels. The increased risk of aneurysm has been listed as an indication for clinical and radiologic surveillance in these patients. Another associated condition is a congenital Horner syndrome. And if you remember, our patient had a congenital ptosis of her left eye. However, her pupils were equal.
Dr. Ohood, we have 2 minutes.
Okay, these are published cases of agenesis ICA associated with ipsilateral Horner syndrome and hypochromia iridum. So if you notice the first patient in A, he has ptosis, but his left eye is lighter than his right eye. And you can see in these 2 different patients as well, the right eye is lighter than the left eye. This is because the deficiency of sympathetic activity due to the absence of the ICA can interfere with melanin pigmentation and lead to this. This has only been reported in 10 cases in the literature. So other associated condition, agenesis of corpus callosum, meningocele, neurofibromatosis. So what are the things to consider? Recognizing carotid anomaly is key in thromboembolic disease and essential during carotid endarterectomy since both brain hemispheres might depend on the diseased carotid. And ICA hypoplasia has been mistaken before with a critical carotid stenosis, which was a published case, and they only discovered it after doing a carotid endarterectomy, which can lead to a significant impact. So failure to recognize the type D of this type, it can have grave implications during transsphenoidal hypophyseal surgery. So take-home message, recognition has a significant clinical importance in neurological localization. Hypoplastic carotid canal differentiates congenital absence of the ACA from other causes. An absent ICA is associated with cerebral aneurysm and patient deserve radiological surveillance. Important implications during carotid endarterectomy and transsphenoidal surgery. And if you see a Horner syndrome plus hypochromia iridum of the ipsilateral eye, it's highly suggestive of early life sympathetic injury. And these are my references. Thank you.
Thank you, Dr.
So, thank you very much, dear Dr. Ohood, and also Dr. Alrushaid. It was a very nice case presentation. Honestly, I learned, and it was a great review for me. So now it's my pleasure to introduce our first speaker, Dr. Mohamad Abdalkader, who will present intracranial occlusive disease, case-based spectrum of pathology and treatment. Dr. Mohamad Abdalkader is a board-certified diagnostic and interventional neuroradiologist at Boston Medical Center and an associate professor of radiology at Chupanian School of Medicine. He earned his medical degree from Lebanese University in 2011 and completed his radiology residency in Lebanon and Belgium. He holds diploma in radiology, a specialty in interventional radiology from Europe, and completed fellowship in diagnostic and interventional neuroradiology at BMC, joining as an attending physician in 2018. At BMC, Dr. Abdalkader evaluated patients and performed neurovascular procedures, including acute strokes, intracranial aneurysm, coiling, carotid stenting. He has over 190 publications and has participated in research on acute stroke management, cerebral aneurysms, and intracranial vascular malformations. He is also an invited speaker at various conferences, a journal reviewer, and independent imaging agitator for stroke and other studies. Dr. Abdalkader, please.
Thank you. You're able to hear me, right?
Yes, sure.
Awesome. Okay, well, thank you very much for this opportunity. And I will be glad and happy to talk to you today about the intracranial occlusive disease. So we're going to review a few cases, and we're going to review like the different causes of stroke other than embolic disease that we typically see. So I have no disclosures. I'm going to start with this picture showing like, typically stroke patient will present with a clot, right, coming to the brain from either the heart or the big other like large vessel. And the clot will sit and cause the blockage and cause the stroke. But there are other potential causes of this stroke. So this is, for example, an image showing that there may be some stenosis although we don't see the stenosis a lot in the intracranially, but this is one of the potential causes. And there are other causes like moya disease, vasculitis, RCVS, or like atherosclerosis, as we mentioned. So it's going to be the next case will be mainly focused on angiographic appearance and the endovascular treatment of it. So, and this is an image showing like 3 different patients. So this is an angiogram of the carotid artery of 3 different patients. And the 3 patients, they have supraclinoid ICA occlusion. So this is the cervical ICA, the cavernous ICA, this is the ophthalmic artery in each patient, and just they have this, what we call the supraclinoid ICA occlusion. So obviously those 3 different patients, they have 3 different pathologies. So if we look to the first one, you can see, if you look closely, you can see here clearly the appearance of a clot sitting inside the artery. So this is the artery. You can see this kind of concave or like this something sitting inside. We call that the convex side or the crescent shaped side. And this is usually it's relatively easy to treat, right? We can go with a stent retrieval. We can just take the clot out using the stent retrieval. And after you do the thrombectomy, the vessel is completely normal, right? Now, the second patient it's more kind of triangular shape occlusion. And we can see this also on the MRA or on the CTA, where we see the typical tapering shape of the tapered shape of the artery, what we call the triangular sign. And when this patient, this is usually the triangular shape, is usually there's something sitting within the vascular wall, not only within the lumen of the blood vessel, but the vascular wall has some problem. And usually those type of occlusion or stenosis, they don't respond typically to stent retrieval, right? Because even if you clear out to put the stent retrieval and pull the stent retrieval, you may create a channel, as you can see here, but the vessel wall is still diseased. So for those patients, you may need, or you will need additional intervention like balloon angioplasty or to leave intracranial stenting to be able to achieve the recanalization. So this is the intracranial atherosclerotic disease, or what we call as ICAT. So ICAT-related LVO is very common, actually, especially in Asian population and Black or African-American, and also like Hispanic population. We see it may represent up to 48%. So almost half of the patient with large vessel occlusion, they may have some underlying ICAD or intracranial atherosclerotic disease. And usually the diagnosis, we can think about 3 different stages of the diagnosis. We can diagnose this before the procedure, right? Especially if the patient does not have an AFib. If the patient has AFib and has, occlusion, we think that it's embolic, but the absence of AFib, the absence of the hyperdense sign, if there is a clot that's coming from the heart and sitting, usually it will appear hyperdense. So the absence of the CT hyperdensity of the occlusion, it's also a sign there may be an ICAD. The fact that there may be already some subacute infarct in the same territory of the occlusion, right? So this usually when it's multiple age territory, multiple age infarcts, this is also a sign that we might be dealing with an ICAD occlusion. Now, vascular imaging before the intervention, as we discussed, you may see the tapered narrowing, not like the very abrupt cutoff. You can see this triangular shape, the truncal type of the occlusion. If it's embolic, usually it will lodge at the end of the vessel or at the proximal part of the vessel. But if the occlusion is in the middle segment of the vessel, let's just say this is segment, when the occlusion in the middle, this is more likely to be an ICAD. And if there are multifocal stenosis in the same territory. So this is also an indicative sign that there may be an ICAD of that. Now, when we do the procedure, if we do the thrombectomy and open the blood vessel, when there is residual or recurrent stenosis, this may be a sign of ICAD. Or if open the blood vessel and then a few minutes later, the vessel will shut down. So the reocclusion on follow-up is also a very important sign of ICAD. So how do we deal with ICAD? As we said, like typically the contact aspiration, the aspiration with the catheter or the stent retriever or even the combined approach, they don't really work very well on this. And we will need to what we call the rescue approach. We need either to give some medication or to give some, put a balloon and inflate the balloon to open the stenosis. Or very commonly, we may end up leaving a stent inside the brain to open this blood vessels. So let's just start with the first case. So she's a 72-year-old woman who woke up with a weak. She woke up weak and numb in the leg. So her symptoms resolved at like 7:45, and then her son brought her to the ER. In the ER, she was complaining again with complete right-sided plegia and aphasia, and she was hypertensive up to 200 millimeter mercury systolic. So I'm just focusing on the clinical history here because this is the typical way of an ICAD-related occlusion we present. They have waxing and waning of the symptoms. They improve. They get symptoms. They get their blood pressure up, and then they improve a little bit. But then the blood pressure shut down a little bit, go down a little bit, and then they will have more. So this kind of waxing and waning symptomatology, this is very indicative of ICAD-related LVO. So this is the CT scan of this patient. You can see that there's already some established infarct in the ACA territory, right? You can see the hypodensity here in the left ACA territory. And the left MCA territory looks very clear. We can see clearly the basal ganglia, and we see the cortex. So there is really only established infarct of the ACA territory. On the CTA imaging, you can see here that there are 2 findings. So the first finding is there is a stenosis of the M1 segment, right? So this is the ICA. There may be some narrowing here. This is the ACA. But at the mid segment of the MCA, the M1 segment here, you can see that there is severe tight stenosis. And this is a sagittal review that there is also a blockage of the ACA territory, right? So we're going to get the perfusion here. So the perfusion imaging, you can see on the perfusion imaging also, we know from the CAT scan that the ACA territory is completely infarcted. It's the core infarct. But we can see that the MCA territory, although that there's some hypoperfusion to the left MCA territory, we know that there's stenosis, but it's not completely or irreversibly damaged yet. So this is just showing the core infarct in red and the penumbra in the green. So in this case, right, we can see here again the occlusion of the ACA. This is the severe stenosis of the MCA. In this case, I'm not going to intervene on the ACA because I know that it's already completely infarcted, right? I'd rather intervene on this ICAD stenosis here, right? So this is, as we said, that usually stent retrieval because we know that this is an ICAD-related stenosis. We're going to do angioplasty and stenting, or this is really, and this is after the procedure. So this is really a scenario that, where we don't have to intervene on the occlusion, we would rather intervene on the stenosis. And it can be that this occlusion is recent and the patient is not getting any more collateral from the ACA. That's why they became symptomatic. But I did not really want to recanalize the ACA because I know from the perfusion and the CAT scan that it's already irreversibly damaged. It's very hypodense. So I'd rather intervene on the stenosis rather than the occlusion in this case. This is just the follow-up MRI showing that we know already that the ACA is completely infarcted on diffusion-weighted images, and this is the MCA territory, that very tiny stroke here on the. So case number 2, and this here is very also important to, we discussed that the subacute infarct territory. If you look to the CT scan, you can see that there is already some hypodensity in the left coronal, left subcortical white matter, and on the CTA you can see this is the 3D RA CTA. You can see that there is occlusion here on the M2 segment of the MCA. So ICAD is very important. Very typically we see it in the ICA or the M1, but it can also see in the M2 territory, right? So this is the angiogram. Obviously, very typically those patients usually are tortuous. You can see here the tortuosity of the cervical ICA. This is the MCA. You can see here the triangular shape of the occlusion. It's just what we call the triangular shape. And you can put the stent retrieval here. You can create some channel, but there's already some stenosis here. So we do first pass, but there's still, you create this channel, but there's still something sitting there, right? So in this case, we know that, okay, well, we did not get, open significantly here. So we're going to do the intracranial stenting with balloon, coronary mounted balloon angioplasty and the stenting. And this is the image before and after. So again, this is what we call ICAD LVO. The patient probably had 80 or 90% stenosis. At some point, they completely occluded this branch, occluded the whole territory. We do a pass with stent retrieval thrombectomy to create this channel, and then most often we need to place a stent to open these blood vessels. This is the CT scan after. You can see this is the stent that we placed inside the brain, and this is the subacute infarct that we already know, or like the infarct that in the white matter here, but most of the MCA territory has been saved. This is just another example of M2 stenting. So this is before and this is after thrombectomy. This is the ICAD-related LVO or the stenosis are not very easy to treat, and usually they are challenging. One, because as I said, usually those are patients have a lot of risk factors. They are elderly. They have some tortuosity of their blood vessels. This is really technically challenging. Like, for example, this patient who presented with right MCA syndrome, and we can see on the CT scan that there is severe stenosis of the distal M1 segment here. And look to those arteries, very tortuous, even on between the brachycephalic and the common carotid artery here, there's severe pink or folding of this. So it's very difficult to get across. So we ended up trying from the femoral through the aortic arch. It was not even possible to get through. Then I ended up going from the wrist to retrans-radial, and you can see the significant tortuosity through the wrist. So finally, so that's the idea here, that those are very technically challenging, and you have to really have the sufficient tools to be able to achieve good intracranial access. Like, for example, here after using an intermediate catheter, we were able to go just to the facing of the stenosis. So this is the catheter here, this is the stenosis, and we place a very tiny small coronary stent to open this blood vessel. So this is before and this is after. You can see the significant improvement of the blood flow after stenting, and this is the follow-up CT scan of this patient after stenting. This is the stent that we placed, and this is the MRI after, showing pretty much the whole MCA branch is territory is saved. So unfortunately, we still don't have a dedicated or good intracranial stenting to do those procedures. So what we use coronary stent. Those stents that are meant for the coronary arteries because they have the balloon built in. So what we call balloon mounted stent. So they are meant, like in the coronary arteries, the most common pathology is atherosclerosis. So that's why, those are, unfortunately, those coronary tools or the cardiac tools, they are not well suited to use intracranially because of the tortuosity. And sometimes, even this, because of the lot of challenging technique, they may fracture and fragment. So it's very important to keep in mind that the treatment of this is challenging, and we really have to be optimized to treat this. So sometimes we don't need even to stent. Sometimes if the patient is not, because if we're going to decide to place a stent in the brain, the patient should be on blood thinners, usually 2 blood thinners, and some of those patients, they may have a bleeding. So this is an example. You can see here, there's M1 stenosis, and you see how the triangular shape of it, we put initially stent retrieval to create a small channel here. and then we just did balloon angioplasty without stenting. And some balloon angioplasty, we know that this patient will probably recur and will have the stenosis, but at least in the acute setting, you can see here before and after, we create this channel with even pushing with the balloon. So balloon angioplasty is an option. And this is a great example where this patient also presented initially with M1 occlusion, but he already has some hemorrhage in the brain, and he's very young, is morbidly obese, 600 pounds, but he is very young, so we have to give him the best chance. So for this patient, we did first the angiogram. You can see here this M1 occlusion. We created a channel with stent retrieval, but there's still not enough blood. This patient is not good candidate for stenting because you cannot give him blood thinners because of the bleed. So we just did a balloon angioplasty with a track balloon, very small, tiny balloon, to give enough blood flow to the MCA territory. And this is just the follow-up CT scan. So balloon angioplasty is also a treatment option of this patient. We know that it's not perfect, but it's good in some situation where blood thinners are contraindicated. So we discussed the intracranial stenting, we discussed the balloon angioplasty, and then what about the intraarterial treatment? So this is a patient who presented with left-sided weakness just in the leg. You can see the CAT scan, there's already some infarct, there's already some probably loss of the gray white matter in the ACA territory here. And on the CTA, you can see that there is an A2 or actually A3 occlusion here. So we did the angiogram just because the patient was disabled. He's not able to move at all his leg. So you can see on the angiogram here that this is the A2 segment of the ACA. This is the A3 segment, the pericallosal artery is occluded here, and this is very small artery to treat, right? This is even the A2 segment, but this is very small. So here there's a great option here. We can go. We don't have to put any tools inside the brain. We just put some medication. So this patient ended up getting IA TPA, so intraarterial TPA, and after the TPA, you can see we created the channel, and most of the ACA territory is back. So IA TPA is also a treatment option for those patients. Now again, we just try to preserve it for patients with very small vessels or when we cannot really go very distally. So this is an option of intraarterial TPA is an option to consider. Especially in the Asian population, the ICAD, the atherosclerosis, is more common in the posterior circulation, especially in the basilar artery. So this is just an example. The patient presented with, again, they typically present with waxing and waning symptoms. At some point, they present initially with some focal symptoms. So this patient presented with expressive aphasia, left-sided weakness. Then in the ICU, he really become completely obtended. And he presented with, this is the angiogram. On the CTA, there was suspicion of basilar artery occlusion, but if you look carefully on the angiogram, there's severe multifocal or multi-level stenosis that come here maybe 80 or 90% to 99%. So this multifocal stenosis, remember that this is the vertebral artery here, this is the basilar artery, this is the ICA anterior, and this is the superior cerebellar artery. So this is so for this patient, we will use combination of the above. So we're going to use initially some balloon angioplasty distally, then we're going to place the first stent and place another stent and place a third stent to really achieve, those are, I'm not sure if it's showing well, but those are 3 intracranial stents placed to achieve the recanalization. And this is the angiogram of the left vertebral artery before and after. Obviously, this is enough. You can see significantly more blood in the posterior circulation. And this is the patient 3 months later. So initially, unfortunately, because of the 2 negative trials for intracranial stenting, we've been a little bit, hesitant to place in the stent. But this patient presented 3 months later with really MRSF2. He's has some motor weakness, but he was able to dress himself. So those treatment is really very successful. So that was the first topic of ICAD, intracranial occlusive disease, the ICAD. Now, what other differential diagnosis? Calcified clots, right? So this patient presented, he's very young. He had a history of endocarditis 10 years ago, and because of dental procedure, he presented with aphasia and right-sided weakness. He got TPA, although retrospectively, we noticed that there was some bleeding on the baseline CT scan. But he got TPA, this small bleeding was not noticed, and was transferred for endovascular treatment. So this is the first pass. You can see there's a blockage of the ICA. This is the second pass. So it was very technically challenging because if you look back, the occlusion here is extremely dense, is as dense as the bone. So this is a very typical appearance of calcified clot. So this is rare, but it's very important to keep this in mind. And whenever we see a patient with endocarditis and calcified clot, there's only one differential diagnosis here. The differential diagnosis here is a fragment of the valve of the heart fragmented from the infective endocarditis. And usually because it's infected, we know 10 years ago, so usually they become dystrophic and become calcified, and the fragment of the heart or of the valve of the heart will fragment, break down, and go to the brain. And those are extremely challenging of this. So the home lesson that, one, if a patient with history of endocarditis, you have to keep in your mind a calcified clot as differential diagnosis of the stroke. And most importantly, TPA, even without the blood, is relatively contraindicated with infective endocarditis because those may present with mycotic aneurysms and risk. So the TPA was indicated. So unfortunately, this patient, after we failed to achieve recanalization, he bled during the angiogram, and this is the follow-up CT scan. So this is the clot that we will never be able to take out because it's calcified. And this is the bleeding. He had subdural hematoma. He has left hemisphere parenchymal hematoma. But also interestingly, he also bled on the other side, right? Even though we did not do any intervention on the right side. So I think the bleeding is after the TPA, those patients with infective endocarditis and calcified clot, they tend to bleed so often. And again, this is the CT scan before is showing that this tiny bleeding here. So we did this, this is not our study, but the idea here that patient with infective endocarditis, they are very high risk of bleeding if they got TPA. In one study, 9 out of 11 patients, so approximately 80% of the patient, they bleed after TPA infective endocarditis. And those usually present with calcified clot. So this is just another example of calcified clot. You can see this is the CT scan without contrast. You see the extremely hyperdense clotting in the right MCA territory. So we learned from our mistake, right? For this type of occlusion now, for the calcified clot, we optimize. We do very big catheter, aspiration catheter, and stent retrieval. So we use different techniques to optimize of our recanalization rate. For this patient, we're able to achieve good recanalization initially, and then this is before and after, but we notice that there's some area here that is still missing, right? So if you look carefully, there's still also very tiny thing in the one of the dominant inferior division here. So we decided to go after it. And this is the clot that it's extremely tiny clot, but you can see how the white color of it. So it's technically not a blood, it's calcified tissue or calcified structure that's causing it. This is just another example of so this is the CTA. You may think that the CTA, that those vertebral artery on both sides that are patent because it's CTA, but actually those are calcified clots on both sides, right? So on this patient, we had a CAT scan. So this is patient presented with a basilar occlusion, right? Because both vertebral artery here. So this is a CTA of the same patient a few months before. You can see that the artery are patent, but now here you can see this intracranial vertebral arteries bilaterally are heavily calcified. Compared, this is the contrast opacification of the vein or the artery here, and this is a calcification. So again, this is the normal artery here, but this is the calcified. So basically, this patient presented with bilateral, heavily calcified clot or embolic clotting of the bilateral vertebral artery. So this is the angiogram. This is the right vertebral artery showing the occlusion here. And this is, put the stent retrieval. Those are very heavily calcified. The stent is not going to open up. And after I open up to some clots, there's a clot migrated to the basilar tip, but finally we're able to achieve complete recanalization. And these are the clot where the calcium, the chunk of calcium or rocks coming out of the brain. So you can see the color of them. They're not like blood. They are calcified. So basically this is, just the calcified, the embolic. Those are, again, for the same patient. Those are the calcified tissue taken out with the stent retrieval. Now, we're just talking about the infective endocarditis, but sometimes if it's acute infective endocarditis, the infective tissue will go up and cause the clotting, right? So this is a clot that I took out of the brain a few years ago. And if you look very carefully of the clot, it's literally a combination of pus or infection. And when we send it to the culture, it will came up like it grew up some weird germs, and the patient ended up with infective endocarditis. So intracranial occlusive disease can also be caused by calcification, by infection, by tumor. So this is something that you keep in mind. And this is a study we also did about like the endovascular treatment of infective endocarditis related to vascular occlusion. It's much more technically challenging, as we discussed. There is high rate of hemorrhagic transformation. As you can see here, up to 50%, unfortunately, of those patients may end up having also bleeding of this. So another differential diagnosis of intracranial occlusive disease is intracranial dissection. So this is a patient, a young patient who presented with right MCA syndrome, you can see here, but typically, if you look at those angiogram, you typically don't see this very beaded shape of the ICA, right? So this is the ICA, maybe some fibromuscular dysplasia appearance here, right? So this is just the cervical ICA, very irregular, very beaded shape. And if you look to the occlusion here, even though we place a stent retrieval here, but after the stent retrieval thrombectomy, you can still the typical triangular shape, right? So just because of the history of fibromuscular dysplasia, it's typically in the neck. So we tried many times to open this blood vessel, but it was not opening up. We suspected that this is an intracranial dissection, right? So it's very tapered, as you can see here. So we went through the fibromuscular dysplasia and we placed this as the catheter in the ICA. So you can see here, this is a very long segment. It's not even typical for ICAD. ICAD usually are very short segment, but as you can see here, there's a very long segment of stenosis that, you know, we put a balloon angioplasty first and then stent, and this is after the thrombectomy. So that's before, that's after. The patient actually did really very well, good recovery. The idea here that intracranial dissection is something that we have to suspect if the patient, they are at risk of dissection, like patient with fibromuscular dysplasia or some patient of collagen disease or anything. So you have to keep in mind that although it's very rare and very difficult to confirm or to prove its dissection, but the other idea that you try to treat like embolic, right? If there is occlusion, you try to treat aspiration, stent retrieval, but if it does not open up, you have to think of leaving a stent there because this could be a dissection. And sometimes we try a lot of time to try to take the clot out, like in picture that, but the vessel does not open up. But sometimes what comes up on the stent retrieval, right? Like you can see here, that instead you typically the clot will stay inside the stent retrieval, inside the stent. So those are a few patients that I had. I tried many times to open the blood vessel, but it's not opening up. And rather there is soft tissue around the stent from outside. So this is basically just the vascular wall. Like for example, this is the stent retrieval here, and you can see the vascular tissue. I do suspect in this patient that the underlying cause, again, it's very difficult to prove, but when you don't get any clot, but you rather get like this circumferential, intimal, whatever, I do suspect those are usually related to intracranial dissection. So another differential diagnosis of intracranial occlusive disease is vasculitis. So for example, this patient presented with recurrent left MCA stroke, initially in the corona radiata here, some frontal and different age strokes, right? This is already some established stroke here with kind of multiple age. We do the CT scan, you can see this kind of tapered narrowing of the ICA. And we do the angiogram here, you can see that you know, kind of the different, this is the right side, there's tapered, sorry, actually, this is the left side. You can see kind of the tapering, the rounded shape type of the occlusion. There is a lot of collaterals from, you know, from the other side, from the ACA. So, and it's not ICA agenesis, it's probably here, we know that the artery here is diseased. You can see that on the CT scan, the bone channel, what canal was there. And there's good collaterals from the PCA to the left MCA territory. So when we do, and for those patients, usually they are young with the recurrent, we do vascular wall imaging. So vascular wall imaging, I'm going to show you this first picture. So vascular wall imaging is a high resolution imaging. We do a high resolution MRI and we give contrast. So this is what typical in ICA appear. There's a flow void. This is the ICA, very dark. But on the left side, the left MCA, the left ICA, it's very avidly enhancing. This is the rest of the MCA. So this segment of the MCA is very strongly enhancing. It's taking the contrast very avidly. This is just a coronal ICA here. Coronal MRI showing the strong enhancement of the A1 segment, the M1 segment of the ICA, and even the petrous. So this is very, very diagnostic of vasculitis, right? So when we see stenosis and we cannot explain it, and we do the vascular imaging, when there is a strong avid enhancement, we usually suspect a vasculitis. And in fact, this patient underwent like chemotherapy with steroids. And they just start with steroids, and sometimes you go even stronger than steroids, and they usually improve if there is no irreversible damage of their brain. This is just another example. Very young patient presented with this internal capsule stroke, right? Restricted infusion here. A very young patient, no risk factors at all. You can see this is the angiogram. You can see that there is some already some, the choroidal artery here, which is the territory of the internal capsule. You can see the choroidal artery here. The first segment is patent and good in size, but then this segment is a little bit tapered and abnormal on the angiogram. The ICA also abnormal. Also, if you look to the ACA territory, is a little bit abnormal here. So a young patient with focal infarct, with no explained, you can see this is the vessel wall imaging. You can see very typical, what we call the tram track enhancement. So this is the right ICA, but here the ICA on the left side of the proximal M1 segment, they have very circumferential enhancement. Also, if you look to the this is sagittal view. This is the ACA. You can see this tram track enhancement. Those are also very suggestive. This is, again, cross-sectional. This is the right ACA. This is the left ACA with this kind of circumferential enhancement. Those are also very typical. This patient underwent a biopsy and was confirmed to have a primary vasculitis, and he was treated by steroids. Also, this is just for the sake of time. We're gonna just, this is the last example. So the RCVS, so sometimes patient with after, heavy exercise, and especially if they are like, drug abuser or they take some drugs, they may present with severe thunderclap headache. We do the angiogram, there's multifocal narrowing. We give them verapamil or some vasodilator, and the vessels will improve significantly. So RCVS, especially in occlusive stenosis with typical headache in young patient, you have to keep in mind the RCVS, which is vasoconstrictive, reversible vasoconstrictive syndrome. So briefly, in summary, not every occlusion in the brain is embolic. You really have to keep the differential wide and broad. Intracranial atherosclerotic disease, usually in Asian or African American or Hispanic, with a lot of vascular risk factors. This is the typical appearance of it, but also vasculitis, RCVS, and Moyamoya disease might also cause intracranial occlusive. The talk is also more like focused and targeted for endovascular treatment, but the diagnosis is really very important. Thank you very much, and I'm happy to take any questions when it's the time.
Thank you so much, Dr. Mohamad Abdalkader, for a very elegant talk and detailed and interesting cases. Thank you so much. So next, we would like to welcome Dr. Athari Salmeen, who will talk about updates on carotid artery disease management, symptomatic and asymptomatic. Dr. Athari Salmeen is the adult neurologist, obtained her board and fellowship in stroke from Vancouver, Canada, and she is a specialist in stroke and head of the stroke committee at Jabir Al Ahmed Hospital. She also a member of the thrombectomy team in Kuwait. She is a clinical tutor and program director of adult neurology in Kuwait. Dr. Athari is a pioneer in stroke neurology. Dr. Athari, you are welcome.
Okay. Assalamu alaikum. Thank you, Dr. Nazar, for the introduction and the organizer of MENASO to include me. And I have to salute my juniors for giving excellent talks on top of Dr. Mohammad's talk earlier as well. My topic today is supposed to be about update of the carotid management. Dr. Mohammad did a great job covering the intracranial, so I'll just cover the extracranial part. I have no disclosures. We'll briefly talk about the diagnosis of carotid artery, going through the management for asymptomatic, symptomatic, as well as the non-stenotic carotid and where we're at in the time being. So how we're diagnosing, most of the literature and the focus when it comes to carotid artery disease, as you all know, has been for the stenotic part. So it makes sense for the diagnosis is that I'm trying to look for that stenosis in order to try to manage it accordingly. There is more than one way to measure the stenosis, whether you want to do ultrasound, CTA, contrast enhanced MRA, and they all have quite the good sensitivity when it comes to occlusion, and also an excess sensitivity for stenosis as well. Most of the time, however, you can find that centers, especially where interventionists are there, they would prefer combined measurement, especially if the lesion has calcifications, to combine, for example, ultrasound with the CTA or ultrasound with the contrast enhanced MRA. And according to that classification, it goes to mild, moderate, and severe. And we always care when it has a moderate severity of 50% or more. So what the guidelines say, Only the European Society for Vascular Surgery as well as ESO have specific paper to target carotid artery disease. Otherwise, in the American and the Canadian, they have it as part of the secondary stroke prevention, but they still do include carotid artery management. Overall, we do provide, the guidelines offer like best medical management for all carotid artery stenosis, whether it was symptomatic or asymptomatic. Sorry. So that will include what AHA now applies like life's essential 8. So that will be healthy diet, physical activity, healthy weight, healthy sleep, avoidance of smoking, healthy levels of blood lipid, blood glucose, and blood pressure as well. And those 8 really come as well from the interstroke paper earlier that provided that if you control those risk factors, you can prevent a stroke by 90%. So we do take it quite seriously. So it is not just a matter of adding on the antiplatelet. Comes our role as a physician when we provide the patient with behavioral counseling, whether if they're a smoker, they need to go for smoking cessation clinic. If they're obese, they go for a nutritionist or metabolic clinic to offer some sort of like bariatric surgery or one of those injections. If they have limited mobility because of previous injury, then we can refer them to physiotherapy or PMR. This is in addition to controlling the risk factors. For example, for the high lipid profile, we start with high dose statin, then we can escalate with adding on ezetimibe, PCSK9 inhibitor as well to reach that target level of LDL less than 1.8. Overall, we do like high dose of statin, not because just of lowering the LDL level, but also because it has that unique anti-inflammatory property that can help with those arteries if the etiology of their underlying stroke we think is related to a plaque. In addition, for those who have high triglyceride, you can offer Vascepa, antihypertensive medications for those who have hypertension for long-term target less than 130/80. Of course, this long-term target, we don't do it abruptly while the patient is in hospital. We do it gradually because we do not want to lower the blood pressure all of a sudden for those who have carotid artery stenosis, in addition to glycemic control as well as antithrombotic. And because of the advancement we have in the medical management, especially with the addition of statin, there is already an evidence that showed that the risk of ipsilateral stroke in those patients have decreased actually from 2.5% to less than 1% in the past 2 decades. Now, what do we do actually with the antiplatelet? This has been a topic of controversy because some people would advocate antiplatelet for anyone who has asymptomatic carotid stenosis because once we have atherosclerosis in one artery, you probably have it in another artery. So this will be beneficial for the cardiovascular benefit overall in reducing the risk of cardiac event. In addition, the low dose of aspirin also has been shown to improve the progression of the carotid intima media thickness. However, it does not really reduce vascular events and all cause death in another paper. If you look into the European vascular recommendation, they recommend antiplatelet for anyone who have more than 50% of the asymptomatic carotid stenosis. So we can either have a low-dose aspirin or we can do a single antiplatelet with clopidogrel. And if they are intolerant or allergic, you can even do a monotherapy with just dipyridamole. With COMPASS study, now the combination of aspirin and rivaroxaban did show a trend in reducing the event of stroke. However, this has not been significant statistically. We do still offer revascularization for certain population with asymptomatic carotid stenosis if they have an average surgical risk. So that will be the 30-day risk of stroke or death will be less than 3%. If they have a stenosis level of 60% or more, and if they have one of the features to make it a high-risk event. So at that point, the options will be mainly for carotid endarterectomy. Level B will be for carotid stenting, and the stenting has been mainly emphasized for those who are at high risk to undergo carotid endarterectomy. This paper just kind of table just to summarize what are the high-risk features that we talk about, because now we know that it's not really just a matter of the stenosis itself that we care about. So there has been silent infarction or imaging, stenosis progression if you do a follow-up of that stenosis, plaque features, there has been intraplaque hemorrhage, for example, there is impaired reserve, the lucency of the plaque itself, and on the TCD there has been spontaneous embolization and what's so. So if we summarize it from a neurology perspective or stroke recommendation, any patient with asymptomatic carotid artery atherosclerosis, really, if they have it more than 60%, then they will go for intervention. At that point, carotid endarterectomy is the treatment of choice, and they did not recommend carotid stenting as a routine, rather just an alternative if the patient has contraindication. If there is more than 50%, then annual monitoring is acceptable, and there has been no recommendation for routine screening. However, certain populations considered to be a high-risk features may be screened. And so the selective revascularization have been limited on those, as mentioned, who show progression of the stenosis. They have silent infarcts on imaging or evidence of embolization on TCD, the plaque morphology itself that looked a bit like a high risk, and if they have life expectancy more than 5 years. SPACE 2 trial was published about 3 years ago that looked into the asymptomatic carotid and whether to do best medical management, since it has been significantly advanced compared to the NACID and earlier trials in the 90s, and with the intervention with carotid endarterectomy or stenting. And in that paper, actually, the primary endpoint event, which looked into any stroke or mortality, did not show any benefit to undergo those revascularization compared to the best medical management. We still have some ongoing trials to look at that point specifically, including CREST-2, which everyone is waiting for, ACTRESS, and ECS2. ECS2 already completed their enrollment. We're just waiting for the results, hopefully soon. And that will help guide us further whether we should send those patients for revascularization or not. Now, for the symptomatic carotid stenosis, this is really about a carotid that gave symptoms in the past 6 months. And those symptoms may be related to a thromboembolic event or hemodynamic impairment, like a watershed stroke or in situ thrombosis. So the presentation really can be anything hemispheric related, whether it was a motor, sensory coordination, sensory, in nature, and sometimes they can come with non-specific symptoms, but those with non-specific symptoms actually did not, studies did not show any evidence that they will benefit from carotid intervention, at least if they have a single carotid stenosis with a normal contralateral carotid. And always I tell my team, let's not forget the fetal PCA, where you can have a visual PCA territory symptoms related to internal carotid if you have a fetal PCA where the posterior communicating is a large vessel and the P1 segment is hypoplastic. So really the anterior circulation is supplying the PCA. Overall, how we manage it, again, we combine best medical management with revascularization, whether endarterectomy or stenting. Recently, there has been some talk about transcarotid artery revascularization, and mainly this has been about transcarotid artery stenting, really. But there has been really no randomized controlled trial that compared it with carotid endarterectomy or stenting, transfemoral stenting. But the idea is that if we go transcarotid, then they will reduce the risk of future strokes because they did not go or manipulate from the femoral going through the arch and all the plaque that may be resting there. Roadster showed that TCAR is safe and effective, and I think right now they reached even Roadster 3. Roadster 3 is a prospective study, but none of those have been actually randomized. Again, if we try to combine all the evidence that we have from stroke recommendations, so everyone goes for intensive medical therapy with antiplatelet, lipid-lowering therapy, treatment of hypertension, and the choice of intervention has been limited with carotid endarterectomy and stenting. TCAR usefulness is still uncertain, and definitely no evidence for bypass surgery. The stroke severity can play a role on sending the patient or not sending the patient, because if the patient has moderate or severe stroke, then the risk of benefit of that revascularization is really unclear, because what are we trying to prevent exactly at that point? And according to the level of stenosis, for the symptomatic one, if it's less than 50%, usually they do not go for revascularization, and more will go for revascularization. If the patient is more than 70 years of age, then endarterectomy is preferred over carotid stenting. If the procedure is planned to be earlier, like within the first week, then endarterectomy again is preferred over stenting. The timing of the intervention, overall, the evidence has shown the best time to intervene is within 14 days of symptom onset. Sometimes someone may go sooner, and that will be related to the presentation itself. If it was just a TIA, crescendo TIA, or stroke and evolution where the symptoms have not really stabilized to a severe or a stable severity of stroke, and it will be deferred if patients already have advanced MRS, that is, they lost their independence, they have large infarction, or they presented with altered consciousness and drowsiness. How does that play a role in stroke code? With IV thrombolysis, of course, when you have symptomatic carotid atherosclerosis, this is not a contraindication for IV thrombolysis. So those patients still go for IV thrombolysis. However, if they become still candidate for revascularization, then usually the revascularization is delayed to day 6, just to kind of avoid the risk of bleeding associated. For mechanical thrombectomy and those who have tandem lesion. So tandem lesion is when you have high-grade stenosis or occlusion of the ICA with intracranial occlusion. And in those patients, if the patient did not go for rescue stenting for the carotid during the procedure, then they can go for that procedure afterward without any issue if they remain a candidate. That is, if their stroke is not severe, they did good recovery after the mechanical thrombectomy, the size of the stroke, the bleeding risk, and the reperfusion, everything has been well. In patients with tandem who do go, like if they presented with a small ipsilateral infarction, and they can have the synchronous stenting done at the same time, especially if they have a poor collateral, or you anticipate that even with recanalization of the intracranial system, intracranial occlusion, that this patient is still at risk to further develop stroke. But now, is it all about the stenosis? We know that this is not the case, especially with the evidence of ESUS that has been quite a hot topic in the past few years, so much that there has been a specific entity called symptomatic non-steroidal carotid atherosclerosis. So with ESUS, what happened was all the focus has been that this is probably related to underlying atrial cardiopathy, or this has been related to subclinical atrial fibrillation. So all the trials of ESUS really focus on anticoagulation, and those trials came back negative. However, now we know that those patients tend to have, some of them have stenosis ipsilateral to the stroke, and that stenosis is less than 50%. So that would be about 27% of patients with ESUS, and can be up to 50% depending on what you're looking at, really. So that will put them at risk of recurrent stroke up to 0.6% per year, and up to 5% even if they do have those high-risk features of plaque similar to the ones we were discussing earlier, like interplaque hemorrhage. And the pool progression, risk of progression even to go from less than 50% to more than 50% is 11%. So this is quite significant. And those studies actually showed that those patients tend to have that less than 50% stenosis ipsilateral to the stroke, and the high risk feature of the plaque also present ipsilateral to the symptomatic side. And even some papers try to look into the genetic overlap, and they found shared genetic loci that those patients have with those who come usually with large artery atherosclerosis compared with a small vessel and cardioembolic. So what do we do with those patients? Overall, you do your imaging to confirm that this is actually embolic stroke corresponding to the ICA. You try to rule out other etiology. You go as far as even a loop monitor to rule out the cardioembolic source. You see that this patient actually does have ipsilateral non-stenotic carotid. They do have high-risk features on imaging, and they don't really have other infarction in other territories to suggest that it could be potentially other causes, and then you treat them. Overall, all of those tend to have best medical management, and most of the time this does include dual antiplatelets. Some talk has been if they're a candidate for following COMPASS with real dose rivaroxaban and aspirin, or they would go for carotid intervention. We still don't have a good evidence to say, yes, this is highly symptomatic, they will benefit from carotid intervention, but I know some centers already started applying revascularization for those patients. In the European Vascular Surgery recommendation, they recommended to go for carotid intervention if the patient has recurrent spells from that same artery. Thank you so much.
So thank you very much, Dr. Athari, for such a nice presentation and complete review. Now let's open the floor for questions. We invite our speakers to turn on their cameras and join us for question and answers sessions.
Dr. Shareefa, Dr. Mohammed, Dr. Ohood, please turn on your camera.
So for warming up, I have a question from Dr. Mohammed. Do you hear me, Dr. Mohamad Abdalkader?
Yes, of course. Yes, go ahead, please.
Dear Dr. Mohammed, I have a question regarding intracranial stenting. As you showed us, you use the cardiac stent for intracranial stenosis or occlusion. We also usually use this the brand of Resolute Onyx stent for intracranial stenosis. But even in the softest type of this cardiac stent, we have problem when we want to pass from the Church's anatomy and also Church's catheter. When you have a Church's catheter that passes through the Church's anatomy of the vessels, there is a problem. What do you think, or what do you do for this such a severe Church's anatomy for passing this hard cardiac stent?
Yeah, so absolutely, especially with the Resolute Onyx are a little bit better than the old versions. But what we learned to do is just to place a Sophia 5 French catheter, which is 125 centimeter. It's those Resolute Onyx go very nicely into this intermediate catheter, what we call. So put a big catheter, usually it's balloon guide catheter in the neck, inflate the balloon, put the intermediate catheter, which sneak very nicely through the tortuosity, and then advancing the stent through an intermediate catheter will make things much easier relatively, because I showed most of the images that I showed you, you can see that the aspiration catheter is really facing the stenosis. So basically now you have a conduit to get there. Instead of going with the stent through the tortuosity, you're going through the intermediate catheter. So I think this is, and inflating the balloon guide catheter, because usually when you advance through tortuosity, everything will tend to fall down. So I inflate the balloon guide catheter in the neck. I put an aspiration catheter, intermediate catheter, usually Sophia 125 centimeter, and then I advance the stent to the stenosis through the intermediate catheter.
Maybe this inflation of balloon give a little bit engorgement of the of the arterial territory, maybe be helpful.
Yeah.
So thanks so much.
Yeah, of course.
Any other question from audience?
Any question, please?
I can see a couple of
We
questions.
have one question here. No. Okay, continue, Azari. Go ahead.
Go ahead.
It's okay, go ahead.
Alrighty, so one of the question is if antiplatelets recommended for asymptomatic carotid stenosis between 30 to 50% or only lifestyle modifications. So we don't really have an evidence to say to do or not do in those patients. Personally, I would put them on antiplatelets. Single antiplatelets like aspirin should not be very harmful in those patients, especially if we think that they may have some other risk factors. Like it's not just one of those carotid stenoses and then they don't have any diabetes, hypertension, or smoking and that sort of thing. If you're not feeling very strongly and you think this patient is at risk of, for example, GI bleed or what sort, then the other option is that you can send them for cardiology for primary prevention. And then at that point, they can decide if it is worth to give an antiplatelet or not. But for the average risk, personally, I would put them on antiplatelet.
So there's one question, Dr. Adari, also Moya plan of treatment.
Dr. Mohammed, I leave that to you or to Dr. Ghorbani, both.
Yeah, I'm happy to take it.
Talked about.
Yes, Dr. Abdalkader, please, let's go.
Yeah, so unfortunately with Moya there have not been a lot of advances in terms of endovascular treatment, because when they usually present, the stenosis is already very severe, and most importantly, they usually have those collaterals already established and doing the job. So from endovascular standpoint, there is unfortunately nothing to like much to offer for them. But there have been a lot of advances in the microsurgical, with basically the bypass. So they do a lot of direct and indirect bypass. But this is only for severe advanced cases at risk of high risk of stroke. Most of the Moya disease, especially if detected early, we can just do obviously the antiplatelets and just make sure that they are like treat them with secondary, primary and secondary prevention and do like antiplatelet therapy. So most of them, they don't really need like invasive or surgical treatment, but those who might like fail conservative management on optimal blood thinners, they will we do usually refer them to a surgical bypass. And usually most of the time now we are doing indirect bypass rather than direct bypass through the superficial temporal artery. But from endovascular standpoint, we don't have much to. We do an angiogram just to better evaluate the vessels and the collaterals, but the treatment is usually surgical.
So, Dr. Mohammed, another question. When blood flows back post-stenting, what is the chance of hemorrhage in the open vessel?
Yes, that's great question. We fortunately, so those patients, as you probably showed on some of my images, they usually, when they present, they don't present with large core infarct. So they usually present because the collaterals, the stenosis is long-standing and the collaterals are already formed. So fortunately, when they present, they don't present with already big infarct, right? So this is very important because we have not seen any significant or disproportional increase in the intracranial bleeding post-stenting, despite them having an acute stroke. And we can explain that they already don't have, because they have good aspect score, right? So they don't have a lot of arterial damage. So the risk of reperfusion injury, especially bleeding, is actually not significantly high. But obviously, what we are doing, and I think this is very important, we have started doing what we call the integrin. We have like potent antiplatelets. The advantage of that integrin, and this is nowadays like, if most of those patients, they are not prepped with aspirin and Plavix. And if you're going to take the chance to prep them in the same day of stenting, they may have some risk of stenosis of the stent. So we started doing the integrin because it's much shorter time to work, like a very short duration to work. And then if there's any bleeding, you can just switch it off. So I think that, so other than we have not noticed any significant increase of the hemorrhage, but I think using the integrin, which is potent antiplatelets, it can start working rapidly. And even if there is hemorrhage, you can just switch it off. And I think some of the those GP2B3A inhibitors, they can disappear from the body within like 5 to 7 minutes. So the half-life of them. So, but I think that in general, the intracranial bleeding, in our experience, is not significantly higher than the non-stenting group, and especially with using this potent antiplatelets. And you can really do the drip very small dose. I'm happy to share the dose of it, but we used half dose of what the cardiologists are using. So with the half dose of the integrin, we have not seen any increase of the intracranial bleeding.
I might add, Dr. Mohammed, this is even for patients who had IV thrombolysis, right? You would still use it.
Exactly. Yes, exactly. So we don't usually prefer doing TPA if we are suspecting on the imaging wise that they are even for chronic like tandem occlusion, and we think that they have carotid or even intracranial because of the tapered shape. We beg our neurologists, please don't give TPA because it's gonna. But for those who receive TPA, especially if we have bigger data from the tandem occlusion from atherosclerotic related, all tandem occlusion who did receive TPA and the stenting after thrombectomy, they did not have significantly higher bleeding than those without TPA. But I honestly, when there is, stenting, I do need to put a stent in the brain. Even I don't really give much of importance of the TPA. If I need to open the vessel, I just open the vessel and then we can manage the antiplatelets afterward. For TPA, I may probably use a smaller dose, so I can go from 0.5 mics per kilogram to 1 mics per kilogram. The cardiologists, they use 2 mics per kilogram per minute. So I use usually 1, but if they're on TPA, I may go down to 0.5 mics per kilogram. But this is the advantage of integrin. You can titrate it very accurately and yeah.
So there's a question from you, Dr. Athari. Yes, one of audience requested your opinion on integrating anticoagulation in intensive medical therapy, especially in a specific population classified as high risk.
Hey, so this is like leaving it right now to expert opinion kind of thing, because the trials that we have actually showed, at least for the intracranial atherosclerosis, aortic arch, it did not show any benefit of anticoagulation. So usually for the extracranial cervical segment of the ICA, we don't have a role of anticoagulation, except in certain patients if we are trying to bridge them for revascularization. So this is depend on the surgeon that will go for the procedure, if they would prefer, for example, the patient to be on dual antiplatelet before, or they prefer the patient to be heparinized before. Even like in that, the area is still quite gray. Not everyone in agreement use anticoagulation or not for those patients. Sometimes if you think that this is a symptomatic critically stenosis and the patient is going, then you can just have a talk with the vascular surgeon or the neurosurgeon in your center and see if they will agree for anticoagulation. But even at that point, to be honest, I usually add on aspirin to their anticoagulation because I do want that antiplatelet effect still.
Thanks so much. And another question, Dr. Mohammed, one of audience asked from the endovascular laser techniques, shunt or no shunt. I didn't get his mean, but do you have any experience about the endovascular laser using for neurovascular pathology, something like that?
No, honestly, no, I don't have any experience. Like I know that they do something like endovascular radiofrequency ablation of like in the terms of calcified, just to try to decrease the calcification before, but I'm not aware of any endovascular laser technique. I'm not really sure if the question was meant for moya because they mentioned also the shunt or no shunt. But if it was meant for moya, I have no idea about any. I'm not aware of any endovascular laser technique for moya.
A question for Dr. Adari. Is antiplatelet recommended? The small vessel ischemic changes incidentally noted in patients with DM or hypertension?
So small vessel disease really is an entity. It's not just a single diagnosis. It can come with a bleed. It can come with like a lacunar stroke. It can come with silent infarct, white matter changes. It depends what we're trying to treat exactly. Usually, if the patient has a lacunar stroke at that point, antiplatelet is recommended. But if it was just like a silent infarct or white matter changes, we don't usually necessarily recommend antiplatelet for those patients because they are also at risk of developing hypertensive bleeds. It's not really just at risk of developing ischemic stroke. So unless they come in with a lacunar stroke, I would not give antiplatelet for small vessel ischemic changes.
Another question, a patient with ischemic stroke with AFib, when should we be given an anticoagulation? He has no history of any chronic diseases and he has not taken any medication before. So when to anticoagulate the patient?
The full lecture. The timing of anticoagulation really for patients with ischemic stroke is quite a broad topic. We don't have any trial to look into specific time period. We know that the rule of 1, 3, 6, and 12 had come for the warfarin. For the DOAC have been used in 4 to 14 days. It really all depends on the blood pressure of the patient, the size of the stroke on imaging, clinically the severity of the stroke, their history if they had like any microbleeds, previous hemorrhages, and that sort of thing. And then you put it all together really and come up with the best time. But this is like patient specific. It's not really a specific time that can be shared with all patients who have a stroke with AFib.
So I think there's no more question. Dr. Nazar?
Yes, I think no more question.
Okay. Thank you all for being with us today. It has been a truly informative session, and we appreciate your participation and engagement. I would like to inform everyone that the evaluation form for the webinar will send to you within the next week. Once you have completed and submitted the form, you will receive your CME certificate. Thank you very much.
So before we conclude, I would like to take a moment to invite all of you to the 10th MENA Stroke Congress happening from 17th to 19th September 2025 in Cairo, Egypt. This flagship event will bring together leading expert researchers and clinicians from across the region to discuss the latest advancement in stroke care and cerebrovascular disease. It will be a fantastic opportunity to network, exchange knowledge, and engage in insightful discussion that shape the future of stroke management in MENA. We look forward to welcoming you in Cairo. Mark your calendars and stay tuned for many details. Thank you again for your attendance. And we'd like to thank also
Thank you.
The speakers, Dr. Ohood and Dr. Shareefa, Dr. Mohammed, Dr. Athari, for the very nice talks and very useful information that had been given today. Thanks a lot, and thanks, Mina. And
Thank you.
Thank you very much.
Goodbye.
Goodbye.